I recognize the gentleman from Massachusetts, Mr. Auchincloss, for his 5 minutes of questioning.
Thank you, Chairman. I want to begin by lifting up the poignant remarks from the gentleman from Texas, Mr. Vesey, about this committee's failure to do one of its fundamental jobs, which is to exercise oversight and accountability over Secretary Kennedy and Health and Human Services. We're whistling past the graveyard right now. He is, as he said he was going to do, there is no surprise here, gutting the childhood vaccination schedule. This will lead to an increase in morbidity and mortality from infectious disease for children. This is preventable, this is predictable, and it's going to be a tragedy. Shame on this committee for not acting. We have requested repeatedly oversight hearings over the Secretary, over FDA, over his actions with ACIP. There has been nothing that needs to change in 2026. There is action that we can take, though, that is immediate and bipartisan, including with Secretary Kennedy, and that's on community health center funding. The community health centers are bipartisan priorities, and they are struggling through a period of acute financial uncertainty with their federal funding scheduled to expire in just 22 days on January 30th. Repeated short-term funding extensions that limit community health centers' ability to plan for their patients' needs and exacerbate the difficulty of working on already very tight margins. I know that this is true for members on both sides of the aisle, that we value the work of our community health centers in our districts, and we should take action to ensure they have the funding they need to be successful. And indeed, we should be working on legislation to expand that funding and help them triple their reach across the United States. I hope we can work in a bipartisan way to provide long-term health center funding that protects patients' access to comprehensive primary care before the January 30th deadline. Moving to the issues at hand with this hearing, Mr. Lipschitz, I want to address my questions to you. You've talked in depth in both your written and oral testimony about the use of AI, how it can be instrumental and life-saving, also dangerous if used inappropriately or excessively, and that's the case with the use of AI to evaluate prior authorization requirements. There's ongoing class action lawsuits from Cigna, United Healthcare, and Humana about improperly denying claims, which is why I'm working on legislation that would place guardrails around the use of AI for prior auth determinations in Medicaid managed care plans and Medicare Part D plans. My legislation would require these plans to establish an electronic prior auth program, enabling them to meet the new timeliness requirements for plans' prior auth determinations. It would require full transparency about a plan's prior auth requirements and the clinical criteria used for decision-making with public reporting to ensure audit capabilities and annual review of plans' utilization management trends. It will eliminate unnecessary prior auth reviews for certain providers, items, or services for patients with conditions that require ongoing care. And it would implement guardrails by requiring only qualified physicians to make prior auth determinations, prohibiting retroactive denials, requiring a standardized appeals process, and mandating a 60-day advance notice for any changes in prior auth requirements. Mr. Lipschitz, recognizing your expertise in Medicare, and understanding that you haven't been able to review the text of what I'm proposing, but just hearing those broad outlines, do you think that could be an effective addition to prior auth legislation for Medicaid MCOs and Medicare Part D?
Yes, it would be an important start on trying to rein in inappropriate use of AI.
Anything I'm missing that I should be considering?
I think we should ask the question whether or not these tools actually do learn from their own mistakes. I can elaborate unless you have further questions.
If I could, let me try to. What I think I hear you saying is whether the models are purely tokenized LLMs where they're making just predictions, or whether they actually have a worldview, whether they're world models that actually feel like they have inherent logic and are learning.
Could give an example. So in the Medicare Advantage context, we often see plans deny care, ongoing care in a skilled nursing facility, say, when initially care is authorized. The plan will come back and prematurely terminate coverage. The person, if they appeal, they often win, but then the next day or a few days later, they get another denial.
So it's a
and with no change in condition. So we're unconvinced that the machine learning tools are learning from their own mistakes and accounting for them.
Helpful. Thank you, sir. Yield back.
Gentleman yields back now. Recognize the gentleman from Louisiana, Mr. Carter.